Chapter 13 is covering the circulating connective tissue, the blood, um, and it's interrelated with the cardiovascular system. Many cultures consider the blood is the life-giving fluid, and this because it allows the nutrients and the um, oxygen to reach the cells, while also on its way out, it carries away the waste. Um, the heart will pump the blood continuously through the enclosed system of vessels. It's a perfectly closed system. And we'll discuss the heart and the blood vessels in the um, next chapters. If you remember from chapter 4, blood is classified as a connective tissue um, and is a mix of suspended cells in a matrix that is considered an extra um, cellular material. The difference between the blood and other connective tissues is the fact that the cells are not fixed in one position. They can move freely in the plasma and throughout the whole liquid matrix of the blood. When we are looking at the whole blood, this can be described as a viscous or a very thick fluid, and its color can range from a bright red, almost scarlet type of red to very dark, almost blackish type of red. And the color of the blood is highly depending on the amount of oxygen that the um, cells, and you will see which cells are carrying in the blood. Usually, when you will see drawing or representations of the cardiovascular system, you will see that blood that is oxygenated is drawn in red or colored in red, while the blood that is low on oxygen or the deoxygenated blood, as opposed to the oxygenated one, will be colored or drawn in blue. When we are looking at our total body weight, the blood volume will account for about 8% of our total body weight. However, the actual quantity of the circulating blood may differ from one person to the other based on their size and gender, with adult men being higher in quantities than the adult women. We have in men about 75 milliliters per kilo of body weight blood, as opposed to women with only 65 milliliters per kilo of body weight. This being said, if we will do a quick exercise and the math for it, we'll see that for a male that roughly weighs 150 pounds, let's say 68 kilos, they will have about 5.8 liters or 5.4 quarters of blood. And as opposed to a woman weighing about 120 pounds or 54 kilos, she will have only 3.5 liters or 3.7 quarts of blood. And you can see just by saying these numbers that we actually do not have a lot of blood to spare if anything wrong happens. This slide presents you an overview of this lecture. We'll discuss blood functions, blood constituents, hemostasis mechanisms, blood types with examples and compatibility, use of blood and its components, disorders of the blood, and blood studies. Please stop this lecture and take a few moments to review the learning objectives. We'll start by describing the functions of the blood, and we can say in rough lines that the blood participates in three important body functions. The blood is involved in the transportation, in the protection, and in the regulation um, of body functions. And we'll describe each of those. When we look at the transportation function, um, our blood transports many important substances, and those will include the nutrients and the essential gases necessary for the cell metabolism, will carry back to eliminated outside waste products, and will also transport throughout the entire body hormones. Will also transport heat And this will be done by transporting from warmer regions to cooler region. Let's say, as an example, whenever a muscle is in activity, will produce heat. The blood that flushes and goes through that area of the muscle will become warmer just by washing the cells and going around them based on their high metabolism, and will move away and will release the heat accumulated to the cooler extremities. Now, if you, we will see when we'll move forward, when we'll describe metabolism a little bit later in a later chapter, you will see that our body has the ability of modifying the amount of blood that travels through different regions. And by doing that is able to equalize or to change the body temperature, maintain it most of the time. Now, moving into the protective function of the blood. Now, we'll describe the components of the blood, and you will see how some of them will protect our body from losing blood, from bleeding out when a side of our body is injured. You will see how blood proteins and cells protect against pathogens. And a little bit more about that function will be discussed later when we'll go through chapter 17, when we'll discuss the immune system. The body is also able to regulate several functions and will regulate the volume and the composition of the blood in order to maintain its homeostasis. And I will give an example. Now, the kidneys and we have at the level of the hypothalamus a center that is called the thirst center. And those two places, the kidneys and the hypothalamus, will be involved in controlling the overall blood volume in order to maintain a normal blood pressure. And we'll do that through two mechanisms. One will be by regulating the fluid loss in the urine. We may eliminate more or less urine depending on how we want to regulate the blood pressure, higher or to decrease it. If we want to increase or to maintain the blood pressure, we'll lose less urine, we'll produce less urine, while if we want to lower the blood pressure and eliminate fluids, the production of urine will be increased. On the other hand, the fluid intake, because if you look into this, you see that we are looking into two elements. We look into intake and output. So the intake will be regulated by, at the level of the hypothalamus, by stimulating and drinking more, by feeling thirsty. If we need to increase the fluids inside at the level of the blood, or decreasing it when we are not feeling thirsty. In addition to that, kidneys in association with other organs will control the concentration of some microelements at the level of the blood, some blood components as sodium and potassium and calcium. Another part of the regulation that we see at the level of the blood is through those substances that they are both proteins and electrolytes that act as buffers. And those substances help the body maintaining a normal pH, which we know that on an average we want that to be 7.4, but it can be anywhere between 7.35 to 7.45. There are, inside the blood, we have water and a lot of dissolved substances, especially proteins, that they can move freely between the blood and the interstitial fluid. And the interstitial fluid is that fluid that surrounds the cells inside the tissues. And by doing that, the composition of the blood regulates the composition of the interstitial fluid. The blood constituents will be described in the following part of the lecture. And the blood can be divided into two main components. We have a liquid portion that is plasma, and we have what is called the formed elements, which are the cells and cell fragments that can also be divided into three categories. We have the erythrocytes, Um, and their name comes from, if we look at medical terminology now, erythro means red. So they are the red blood cells, and they will transport oxygen, and to a lesser extent, they will transport the carbon dioxide also. We'll have the leukocytes. Um, Terminology now, again, leuco means white. There are several types, and they help in protecting against infections and cancer. And we have the platelets or the thrombocytes that are small cell fragments. They're not even per se full cells, but cell fragments that have a very important function in blood clotting. We'll look at each of those components. And blood plasma, it's about 55% of the total blood volume. Um, in itself, um, the plasma, it's over 91%, it's almost 92% water. So because it's water, it has this high ability to transfer heat, because if you remember what I was telling you in chapter 4, water is a perfect thermostat, is able to um, gain heat to take and intake caloric energy, and to release it when needed. And also because it's water, remember from solutions, is the perfect solvent for all the water soluble or hydrophilic substances. So we have many different substances that will be both dissolved as hydrophilic or suspended as hydrophobic substances in the water. And that's about 8 to 9% of the components of the plasma. While circulating, the plasma components may be added or may be removed. However, the body has that amazing capacity of maintaining what is called a homeostasis, and to maintain this kind of fairly constant level of substances. And one example that we are going back again and again, because it's very easy to understand and very practical also, is the level of glucose, which is the most simple sugar that our body and especially our brain needs to maintain normal functions. So the level of glucose is maintained at almost remarkable constant levels throughout the entire life, with the exception of when the patients will develop a disease called diabetes. Beside the water, we have a lot of proteins, and those are those particles that are dissolved or suspended in the plasma. Most of the plasma proteins are synthesized at the level of the liver, and I will name a few of those. Um, the most important one and the most abundant one will be the albumin, and that's important for maintaining the what is called the plasma osmotic pressure. So if you remember, the osmotic pressure represents the ability of a solution to attract water. So albumin is essential to keep water inside our blood vessels. When the level of albumin is very, very low in diseases of the liver, the water will shift outside the blood vessels, and that's when we see in our patients that they have generalized edema or accumulation of water in their tissues. We have the clotting factors that are necessary for preventing blood loss whenever there is a damaged or injured area or damaged vessel. If you remember, I was telling you that everywhere we have capillaries, so any type of injury, no matter how small, will at a certain degree produce an injury. We have antibodies that are those substances that are necessary to fight infections, and they are produced by certain types of white blood cells involved in the immune response after they become trained. And we have another protein that, or more specifically, is not just one protein, is a number of, it's a group of enzymes that make out for what is called the complement, which is another factor, another element that contributes together with the antibodies in the immune response. Whatever is left, the very small percentage, something up to 1% of the plasma constituents, will be nutrients and electrolytes and some other materials that the body needs to transport. Um, those may be amino acids, that they are results of protein digestion. They may be lipids, a very, very small part of the blood plasma. And the lipids may include cholesterol and fats. Keep in mind that the lipids, remember, fats are not soluble. Water and oil do not mix. So fats are not soluble. So they will be, and because of that, they will be transported through our plasma, which is over 90% water, will be packaged together together with a protein. Because remember that proteins are soluble, are hydrophilic. So the lipids need the help of a protein to be able to be transported in a hydrophilic, in a watery um, uh, transporting material. And they form with the protein what is called a lipoprotein. The electrolytes that we find in plasma will be sodium, potassium, calcium, magnesium, chloride, carbonate, and phosphate. And they have a variety of functions from formation of bones and participation in physiological processes. They may be involved in production of hormones like the iodine that is essential for the thyroid hormones, or to maintain the acid-base balance as the sodium and potassium are present in buffers. In addition to that, we may have hormones, as I said before, waste products. We may found drugs, small amounts of dissolved gases as oxygen, and mainly will be carbon dioxide dissolved in plasma. This is an example um, of how we see under the microscope um, a sample of blood, and you can see the huge amount of the red um, cells around, and those will be your erythrocytes, and you see that they are overwhelming in numbers as opposed to other types of cells. And you can see a big blue one, a little bit bigger than the rest of the erythrocytes, but in this field it's just one, so you can understand what the ratio between those cells is. So the leukocytes will be less and in a way a little bit higher than the erythrocytes. And also you can see some tiny purplish dots scattered around in this field, and those are your platelets. Again, they are not fully formed cells, but fragments of cells that they contain all the products, all the necessary elements for coagulation. So the blood is produced at the level of the red bone marrow. And if you remember from the skeletal system, the red bone marrow is located at the end of the long bones, at the level of the epiphysis, and also in the body of the flat and short bones. All the blood cells have a common ancestor, and this is called the hematopoietic cell, and it's a stem cell. Hematopoietic means blood forming. Those cells have a short life, and they will be produced continuously. Once the stem cells that they have a high reproducing rate, they have a high division rate, will produce cells that will start to differentiate into different types of blood. They all those cells that you see in this image will start from the same stem cell, but they start to differentiate into different offspring lines. Again, very short-lived. That's why the body has a constant need of replacement. And those cells will be, because they have this short life and high reproduction rate, will be the first influence whenever something wrong happens to our body. We'll discuss each of those, and we'll start with the erythrocytes. Again, erythro means red, so those are the red blood cells. They are about, in diameter, about 7 micrometers. They have a disc-shaped structure, and you can see it in this image how they have tiny depressions on both sides. In the central area, with the central area being a little bit thinner than the edges, and this allows them for an increased surface while to bind oxygen while also allowing them to be malleable and flexible when they are traveling through small blood vessels. Because if you imagine that they will have been completely round, they will like a ball, like a ball, they will get stuck in small capillaries and will clog together and will not be able to move. What is particular about the red blood cells, beside their what is called the biconcave shape, is the fact that as a mature form that circulates in the blood, they do not have a nucleus. So they are called an anuclear cell. And also they will lack most of the organelles commonly found in other cells. And as a result of that, because they don't have a nucleus, those cells are not able by themselves to divide and multiply. So they need to come from the hematopoietic stem cells from the bone marrow. Those components are lost as the red cell mature, and by losing them, that allows the cell, it's another adaptation to function of the cell. By losing those tiny organelles inside, the cell allows for more space inside to carry the oxygen. The oxygen will bound inside the red cells through a protein that is called hemoglobin. And hemoglobin contains iron. Once is combined with oxygen, becomes oxyhemoglobin, and it gives that particularly bright red color to the blood. Whenever the blood goes through the lungs, it gets filled with oxygen that will be carried to the tissue. At the level of the tissue, the oxygen will be released, while the red blood cells will carry not as much as before when they were carrying the oxygen. They will load themselves up with CO2, with carbon dioxide, and that will give the blood the darker color. In addition to carrying oxygen and transporting oxygen, hemoglobin can transport hydrogen ions that may act as a buffer, and they balance and maintain the acid-base balance. There is a way to block the hemoglobin ability to carry oxygen, and that happens when the hemoglobin is blocked by carbon monoxide. And carbon monoxide, probably you know because it's standard in California to have it in our houses, those monitors. It's an odorless and colorless gas. However, it's extremely harmful because once this gas combines with hemoglobin, the hemoglobin becomes turns into a stable compound that will never be released from this connection with carbon monoxide. By the way, carbon monoxide represents a byproduct of some type of incomplete burning of fuels as gasoline or petroleum products or coal or wood, especially for those having fireplaces or this kind of stoves inside the house. Also in small quantities is a result of cigarette smoking or automobile exhaust gas. So once the hemoglobin is bound by carbon monoxide, it will be completely blocked and will not going to be able to carry oxygen anymore. At a certain point, if the patient is exposed continuously to this gas, all the red blood cells will be inactivated by being irreversibly blocked by carbon monoxide, and the patient will die by having lack of oxygen. In terms of numbers, erythrocytes are, as you can remember from that microscopic field that we've seen before, they are numerous, between 4.5 and 5 million per microliter of blood. The microliter is 1 millionth of a liter. So again, they cannot reproduce themselves, so need to be replaced constantly. They have a life inside the bloodstream of about 120 days. And after that, their membrane will deteriorate, and the deteriorated membrane will be recognized by the cells of the liver and the spleen. And at that level, the erythrocytes will be destroyed, and their component of hemoglobin and iron will be recycled for body usage and resent to the level of the hematopoietic stem cells to allow them to build new red blood cells. So you can see in our body, if we, in a normal person that has no conditions, and a healthy one, everything is at very high levels recycled. So let's discuss a little bit, how do we regulate the level of erythrocytes? When do we need more? When do we need less? And why? Like everything else in our body, that goes through a negative feedback in order to maintain the homeostasis necessary to maintain the necessary blood levels of oxygen, especially to the level of the brain. So whenever there is low blood levels of oxygen, that will be perceived at the level of the kidney by some special cells that will secrete um, a hormone that is called erythropoietin. And this will stimulate at the level of the bone marrow and will increase the synthesis of the white blood cells. As a result of that, by increasing the number of red blood cells in our blood, more oxygen will be carried, and the level of that was before that low of oxygen in the blood will increase, and again will be sensed back by the kidneys that will stop the production of the erythropoietin. However, that is in continuous balance. It may increase or decrease based on the patient needs. Just to give you a quick example of situations where we may need an increased number of red blood cells is for those people living at high altitudes, like um, those people living in the Grand Canyon, or living in Denver, which is higher in terms of altitude. And you know that by altitude, the concentration, the higher the altitude, the lower the oxygen concentration will be in the air. And as a result of that, as an adaptation, those patients will have higher level, physiological higher level of red blood cells in order to supply the needed oxygen, which is a scarcity in the air over there, to the body. However, this is a process that happens in time. It doesn't happen overnight, and it's an adaptation when we are moving into those higher places. The constant red cell production will require also an adequate supply of nutrients to the stem cells, and especially proteins, because again, the hemoglobin is the protein that binds with oxygen, and to be produced, we need the main elements to do that. Vitamin B12 and folic acids are highly required for production of DNA. In addition to that, for correct production of hemoglobin, we need iron and copper. And vitamin C is also needed and essential for proper absorption of iron from the small intestine. Leukocytes, or the white blood cells, again, leuko means white. They are different from erythrocytes in the way that they look like. Also, they differ in function and quantity. They are round, as opposed to red blood cells that they were biconcave. They have prominent nuclei that have various shapes and size. And in terms of quantity, their concentration is 5,000 to 10,000 cells per microliter. Leukocytes, if we look at the ratio red blood cells to leukocytes, it's about 700 to 1. So the red blood cells are red because of the hemoglobin, that protein that has a lot of iron in it. As opposed to that, leukocytes are colorless. We call them white, but they are in fact colorless. In order for us to see them when we are looking at the microscope, we need to color them, and we use for that lab stains, because otherwise we will not going to see them on a slide. We'll discuss now different types of leukocytes. So they differ in numbers and in size and in shape and in the appearance of some components inside of their cytoplasm, and which are called granules. And those particles are those that are catching the stains that we are using to color the dye that we are using to color the cells when we want to see them under the microscopes. Those granules that we see inside the white cells are in fact lysosomes and secretory vesicles. And if you remember the lysosomes, I was telling you to remember and kind of think about Lysol. They are the cleaning. They are they have inside a lot of enzymes, and they are involved in cleaning and eliminating and digesting particles. Those cells are our main soldiers involved in immunity. We have two types of those. We have the granulocytes and we have the agranulocytes. The granulocytes are those that have many visible granules in the cytoplasm when stained. And they have what is called a highly segmented nucleus. So look at those three images here, and you can see how the nucleus, instead of being nice and round and in one piece, it looks like it's made out of a lot of segments. That's why we call the segmented nucleus. So we have three of those. We have the neutrophils that stain either with acidic or basic dyes, and they make up for most of the leukocytes cells. They can be up to 62% of the leukocytes. We have the eosinophils that are in small numbers, up to 3%, and we have the basophil leukocytes that are less than 1%. Now, basophils stain with basic dyes only, while eosinophils stain with acidic only. So if you look at this image to remember them really quick, you see that neutrophil, it's a little bit purplish. That means that it's a combination. Purple is a color that results from combining red and blue. If you remember from when you were in kindergarten and you're playing with colors. So purple is a result of red or blue. So neutrophils will color with both acidic and basic dyes, red and blue. Eosinophilic will color with red, so only acidic dyes will color them, while the basophilic ones will color only in blue because they are basic. So the eosinophilic cells are involved in allergic reaction, and they increase in numbers whenever the patient is fighting a parasite infection, while the basophil also involved in inflammatory reaction, but have more an inflammatory component more than anything else. I was telling you that we have another type of leukocytes, and they are called agranular leukocytes or agranulocytes, and this is because when we color them, they will lack easily visible granules. And their nuclei are round or a little bit curved, but definitely not segmented like the other cells are. And you can see that it's a huge difference between them. Still, they have huge nuclei, both of those. So lymphocytes, they are up to 38% of the cells in our blood, and they're the second most numerous. They originate in the red bone marrow. However, in order for them to maturate, to fully establish their training, they will go inside a lymphoid tissue and will multiply and divide and develop and maturate in this tissue in order to fully gain their capability of fighting infections. We also have another type that is called a monocyte, which is the largest of all white cells, and they are up to 7%, and they are involved in the process of phagocytosis. And once they mature, they will travel inside tissues and they will develop into macrophage. We'll describe now a little bit the function of the leukocytes. So the main function of the leukocytes will be to protect the body. And they do that by clearing the body of foreign material, any kind of cellular debris, help in fighting against cancer. And probably the most important function is that of identifying and destroying any type of pathogen that may invade the body and cause an infection. Neutrophils and monocytes. So one granulocyte and one agranulocyte will be involved in a process that is called phagocytosis. Phagocytosis means engulfing and eating that foreign material. Whenever there is a pathogen that enters the tissue, and that can be anything, it can be dirt, it can be dust, it can be a virus or a bacteria, any type of foreign particle, the phagocytes will be attracted to the area. And if you look at this picture, you can see how the cell, the blue one, is squeezing itself in between the cells of the capillary walls. It makes itself out from the bloodstream inside the tissue. And inside the tissue will move through some movements that are amoeba-like, will develop like a leg and will grab themselves and will move around, and will be able to reach the area where the infection or the toxic particle is, and will change their shape to engulf. And you can see in the next image, if you're going from A to B, you can see how the blue cell is kind of covering the bacteria up to the point where the bacteria is completely engulfed inside the phagocyte, and by using the lysosomes that are a lot inside, and those are the granules that are colored in blue when we are looking on a microscope. The lysosome has very active enzymes that will destroy the bacteria and will kill it and eat it up. As a response of an invasion, regardless what type of foreign material that will be to the body, the bone marrow feels that as a signal, and both the bone marrow and the lymphoid tissue will go into what is called an emergency production of cells. And as a result of that, what we see in the periphery when we do a blood test, we'll see an increased number of white blood cells. So this can be an indication of an infection or an active process that happens in the body, and the body is kind of fighting it. In the process of battling any type of pathogen, the leukocytes themselves will be destroyed, will be damaged. And at a certain point in some areas, we'll find a mixture of dead and living bacteria together with dead and living leukocytes. It's like in a war field where you have casualties. And that war field full of casualties will be your the regular pus. We call a collection of pus that is localized in one certain area as an abscess. On the other hand, when the monocytes will enter the tissue, they will become larger and larger, and that's the final stage of maturation for the monocytes. They become what is called macrophages. And those are the superstars. They are very big and very strong. And while the lymphocytes will live 6 to 8 hours, the moment that the macrophages will enter the tissue, they can survive over there for days, months, and even years, having the memory of certain pathogens. Some other lymphocytes may become what is called plasma cells. And they are active in producing the circulating antibodies needed for immunity. And we'll discuss that a little bit later in chapter 17. The last type of cell that we have in our blood is the platelets or the thrombocytes. Those are the smallest formed elements. They are very tiny, but they are actually not cells. They are fragments that result from they are released from a giant bone marrow cell that is called a megakaryocyte. They do not have a nuclei. They do not have nucleus or DNA. They do contain huge amounts of active enzymes, and they have inside mitochondria. They need energy. Because they are so small, and they are a result of fragmentation of a mother cell. Their numbers are high in the blood volume, and they vary between 150,000 to 450,000 per milliliter. They have a lifespan of about 10 days. Usually, we say that the platelets will be completely replaced every 14 days. And they are essential in the process of homeostasis or prevention of blood loss. When blood comes in contact with a tissue that is injured, that have the mucosa, the smooth lining of the blood vessel is injured, the platelets have the ability, they recognize that area and have the ability to stick together and form a plug that will cover that wound. As a result of forming a plug and sticking together, they will release chemicals that will complete the formation of that clot and will stop the bleeding. So question number 1 is asking you, what iron-containing protein transports oxygen? Erythropoietin, complement, thrombin, or hemoglobin? The answer is the iron-containing protein transports oxygen. That transports oxygen will be hemoglobin. Hemostasis is the process that prevents any type of blood loss whenever there is an injury that involves the circulation, meaning that the blood vessels is ruptured through that type of injury. Regardless where it happens in our body, if it's inside or outside, if the bleeding is visible or not, if the injury is small or big, the hemostasis process will follow the same, completely the same type of process. We'll start with the contraction of the smooth muscles in the smooth muscles in the blood vessel wall, and that is called vasoconstriction. When we'll discuss in chapter 14 and 15 the cardiovascular system, you will see the structure that contains the blood vessel have that layer of smooth muscle that allows for modifying their diameter. As a result of vasoconstriction, there will be a reduced blood flow and loss from the defect at the level of the injury. The second step will be the formation of the platelet plug. And this is the result of activation of platelets. They will adhere to each other and they will stick to the injury and will form a temporary plug. However, this temporary plug is unstable, is not strong enough to allow for the healing of the injury. In order to be able to heal the injury, we'll need to form a permanent blood clot, and this is the result of the coagulation process. So the clotting process usually is extremely rapid, and it follows a quick this quick sequence, and it's so quick because all the needed elements, all the substances needed for the clotting process are already present in the blood. They are flowing in our blood all the time, and they are ready, available for usage at any given moment. Because of that, there is a continuous and it's a permanent balance that our body needs to maintain between those compounds that will promote clotting, and they are called procoagulants, and those that are preventing clotting, and they are called anticoagulants. In a healthy individual without any type of injury, the anticoagulants will prevail, will be more prominent, and will prevent the blood clotting inside our blood vessels without a given reason. However, the moment that the need for a blood clot happens, that will be the result of a sequence of the coagulation factors that will end up by forming an insoluble web of fibrin that will capture inside elements from the blood, mainly red blood cells, and that's why most of the blood clots that you will see in the scars that you will see will have this kind of darkish red kind of color, because the high amount of red blood cells that will be caught in the fibrin web. So we'll discuss now the process of coagulation. So it's a well-controlled series of events and involves 12 different clotting factors. Those are, in our body, we have 12 different types of clotting factors, and they are designated using Roman numerals, numbers. Calcium ion is one, and it's very, very important. You'll see how it participates in so many physiological activities. We already described it as an essential element for a muscle contraction, if you remember. Yes, it's also essential in building our bones, in maintaining their strength. And now you see another function for calcium at the level of clotting. And calcium, we can find it floating in the bloodstream all the time. Other clotting factors are released at the moment that tissue is damaged, and that happens in addition to activation of platelets. Other clotting factors are enzymes that are produced in the liver, and they are released into the bloodstream in a form that is an inactive form. This form will be activated inside the clotting process. In order for the liver to be able to produce those enzymes, the liver requires vitamin K, and the vitamin K can come from some of the green vegetables and grains, but most of it is produced by the bacteria living in a complete balance with us in the large intestine. Now, as a result of a final step in the clotting reaction, there is a plasma protein that is called fibrinogen. And this liquid type of protein will transform into a solid thread that is called fibrin. In this solid web or thread of fibrins, blood cells will be trapped and the clot will form. The final aspect of it is the maturation of the blood clot. So if we are looking at this picture again, it starts with, look at the left side of your screen. It starts with vasoconstriction, followed by the platelet activation that will form the platelet plug. That's the primary hemostasis. And we have the secondary one that will reinforce the results of the primary one. And through the coagulation cascade, that will make the thrombin, will release the thrombin that will transform the fibrinogen, which is soluble, into an insoluble protein, which is called fibrin. The blood clot will form, and the last step that you see on the right side of this image will be how the clot will degrade once the tissue heals, and how we'll remove the clot, kind of take out the bandage from that injured area through another enzyme that is called plasmin. Now, if you look at the ABC sequence on the right side of your screen, you see that we start with the platelet plug that will stimulate a prothrombinase. Everything that ends with an ase, it's an enzyme, and will be a catalyst, will stimulate the reaction. And the prothrombinase, the enzyme, will stimulate the prothrombin together with calcium to become thrombin. The thrombin will stimulate the fibrinogen to become fibrin threads and to develop the clot. So the final steps will be forming this tough web of fibrin with cells deposited inside that will plug the injury, will stop the injury, and will allow the tissues inside this clot to heal. There are a few methods of hemostasis, and that's when we need to help a patient to, or we need to stop in an artificial way the blood loss. And we have what is called mechanical methods. And that can be done by direct pressure. You're just taking a dressing and you put pressure on a wound and you maintain the pressure until you're mainly adding to the contraction, to vasoconstriction by putting pressure on that and stop on that blood vessel that is bleeding, and by stopping the blood loss. We can do that by direct pressure. We can do that by using sponges or gauze. And another type of mechanical method of hemostasis is to use sutures. When we tie a blood vessel that is bleeding, we can use staples by putting tiny staples on it, or by ligating clips. It's just like a clip that will um, collapse the blood vessel that is bleeding, and will, by collapsing it, will produce a blood clot at that level. Another type of another method that we can use uses a different type of energy, and that will be the thermal energy. And we have the electrosurgery, where we are using electric currents that can be monopolar, bipolar, to seal the bleeding vessels. We can use an argon type of coagulation. We can use ultrasonic waves to seal the blood vessels, or we can use laser energy to do the same thing. They're all producing coagulation of the proteins and sealing of the blood vessels by doing that. And we have coagulation chemical methods that are using pharmacological agents. We can use epinephrine, which is a vasoconstrictor, will collapse, will very strongly activate the muscles of the blood vessels that will constrict. We can use vitamin K to promote the coagulation process. And there are a full other list of pharmacological agents that are used mainly in the OR setup. Question number 2. What will be the correct sequence for hemostasis? Vessel contraction, plug formation, blood clot. Blood clot, plug formation, vessel contraction. Plug formation, blood clot, vessel contraction. Vessel contraction, blood clot, plug formation. The correct sequence for hemostasis is vessel contraction, plug formation, and developing of a blood clot. Our blood is just like any other type of tissue, and will have a way of present itself as self or non-self, like any other cell in our body. And the way that our cells are presenting as self or non-self is based on some substances which are called antigens that are present on the surface of every blood cell in our body, but they are very prominent and important on our blood cells. An antigen, regardless if it's an autoantigen or it comes from outside, will trigger the immune system to respond. And that antigen may be recognized as self, and then the immune system, the so-called um, the police system of our body, will not trigger any kind of response, or will maybe recognize as non-self, and then the immune system will produce against it a specialized protein that is called an antibody. And the antibodies help to destroy any type of offending antigen. So the blood cell antigens can vary among individuals, and they're very important whenever we are discussing blood transfusions or donating blood. The antibodies that will recognize specific red cells antigens are called agglutinins, because they are doing a process that is called agglutination or clumping. Once the agglutination happens, the cells will rupture and they will die, and they will release outside the hemoglobin. And as a result of that, the process is called hemolysis. The process can be very dangerous if it happens in an individual, because they will lose the red blood cells. They will lose the ability to transport oxygen. They become anemic up to the point that can be incompatible with life. On the levels of the on our red blood cells, we have two types of antigens. We'll have the so-called A and B antigens, and we'll also have what is called an Rh factor. here how on the surface of the red blood cells we can see the A antigen, we can see the B antigen, and the Rh antigen. Depending on what type of blood we have, we can show the A, we can show the B, we can show both of them, while the Rh can be either present or absent. And we'll describe both the blood types and the Rh factor. So we have four blood types that involve a combination of A and B antigens. We have the A antigen present, and that's the type A. We have the B antigen present, and that's the type B. We can have both of them present, and those people will have the type AB of blood, while may have people that have neither A or B present, and those will be considered type 0. Now, let's understand how this works in terms of transfusions. In type A patients, they will have anti-B antibodies. They don't have the B antigen on their cells, so for them, the B type is foreign. Therefore, type A can receive type A of blood or type 0 because 0 have neither A or B antibodies. Antigens on their cells. Therefore, they have both antibodies for A and B, and they are called what is called the universal donor. The type A, they cannot receive type B because it will produce hemolysis, and they cannot receive AB because also they have the B component that will be recognized as non-self. Just like in the case of type A, the type B patients will have the type B antigen on the surface. And as a result of that, we'll recognize the A antigen as foreign, as non-self. So they can receive blood from B type, the same type of them. They can receive from 0, which is the universal donor, but they cannot receive from A or AB. Now we have the last type, which is the AB type of patients. They have neither of our antibodies. They can have any type of blood because for them, A is known, B is known, 0 has no antigen, so it doesn't bother them. However, they can donate only to AB. And they're also called the universal recipient. Your AB patients are the easiest ones because they can receive blood from anyone. And this is without even talking about the Rh. Now, if we are looking in the general population, you see that we have the Rh can be either positive or negative for both of those AB 0 blood groups. And you see that the highest number of in the population, the highest number of patients will have the type 0 positive, will be 42% of the patients, with type A positive, 31%, followed immediately by B positive, 15%. So you see that the positives are the highest numbers, with very low numbers, all the rest of them. Now, AB negative, you can see that is the lowest number. This table is summarizing again the blood type, the antigen, the reaction that they may have, and who they can receive blood from and who can they donate to. So if needed, please stop here the presentation and take a moment and review those. We'll discuss now the Rh factor. And about 85% of the population also present on the surface of their red blood cells another antigen group that is called the Rh factor. And it's called Rh because it was discovered at the beginning on the rhesus monkeys. And rhesus is written with Rh at the beginning. It's also called the D antigen. So we have Rh positive blood, 85% of the population will have this antigen present, while 15% of the population will have an Rh negative type of blood. As a result of that, people that do not have this antigen will become sensitized, will develop a sensitivity, will recognize the red blood cells that have this antigen as non-self, and they will create antibodies that on a subsequent meeting with the same antigen may cause hemolysis. And this is very important, especially in for females that they may become pregnant, and this will lead to, if it's not treated and it's not managed properly, may lead to what is called the hemolytic disease of the newborn, and can affect not necessarily the woman that has the Rh negative, but a baby that is Rh positive in a subsequent pregnancy, and I'll explain this in a second. So let's discuss a little bit the hemolytic disease of the newborn. In this situation, we usually have an Rh positive mother that at her first pregnancy with an Rh positive baby, most of the time the Rh will be predominant in terms of genetics of how the Rh develops, and because we are 85% of the population has it, it's a higher chance that the baby will have the Rh positive. So we always need to check that. So in a first pregnancy, the mother's blood will encounter erythrocytes from the fetus, will become combined through the placenta, and the cord will be passed to the mother's body, and the mother will be sensitized to that. With the first pregnancy, nothing happens. The baby will be born and all will be fine. With the second pregnancy, that may be again with an Rh positive baby, the mother already has the antibodies, and the antibodies already know how to recognize those Rh positive erythrocytes, and they may attack them very quick. And as a result of that, there is a cascade of processes will start, and as a result of that, hemolysis of the erythrocytes, the fetal erythrocytes, will be destroyed as a result of that, and the life of the baby, of the pregnancy, will be endangered. Back in the day, this condition was also called erythroblastosis fetalis, and the way that we prevent it now is that at the moment of the first pregnancy, the moment that we recognize that, we treat the mother during the pregnancy and immediately shortly after delivery with what is called an immunoglobulin that is called RhoGAM, that will clear the mother's body from the antibodies that were created during that pregnancy, and in such a way we prevent an uncalled event with a subsequent pregnancy. However, those type of treatments needs to be done with every single pregnancy to prevent future pregnancy from being affected. So how do we decide to perform blood transfusions? So we are looking mainly in the type of compatibility. So definitely the safest transfusion is the same type of blood. Again, type O, not having any antigens, is the universal donor. Can be given to any ABO type. Type AB can receive any, is the universal receiver, can receive any type of ABO type. Something else that we are looking into is the RH. We prefer to give when we don't know what type, we didn't have the time to type and screen the blood of a patient that needs an immediate transfusion, especially in trauma cases. We prefer to give what is called an O negative, because O is the universal donor, and we don't want to sensitize, especially if it's a female during her fertile years that she can become pregnant in the future. We don't want to sensitize them for the Rh factor. The best idea is to do a type and screen. When time allows us, we will do that, and we'll provide the blood type that is typed to the patient's type of blood. Nowadays, we know that the hemolytic diseases and uh, side effects from a transfusion can happen not only from ABO type or RH type, but there are some other microfactors and microantigens that are associated with our red blood cells, and that's why we are trying to go even beyond the typical ABO and RH matching, type and matching of a blood product. The safest probably transfusion would be with what is called an autologous um, blood, which is the blood that the patient before, let's say, a major surgery that is scheduled, they will be able to donate their own blood that will be stored and used if needed after the surgery. Again, whole blood transfusion, most of the days not used anymore. For those major traumas, we have something else. We have a recycling system that will use the patient's blood that is um, harvested from the field, will be filtered through a machine and retransferred, cleaned, filtered, and retransferred into the bloodstream of the patient. So that's an autolog type of transfusion through machines that are called cell savers because they are saving the patient's own cells in the process. Once the whole blood unit is harvested from a donor, the components, the whole blood will be separated into its components by performing a process that is using a centrifuge. That's a machine that will spin in circles at a very high speed and will separate this mixture, because if you remember, the blood is a mixture of blood cells and fluids, and the cells will separate at different levels while the fluids inside will also separate in different ways. We also have another procedure that is called hemapheresis. And that comes from the Greek word apheresis, that means removal. And by using a machine, a special machine that has different, very special type of filter, The blood from the patient can be completely, the whole amount of blood of the patient will be removed through that machine and filtered through that machine and re-transferred back to the patient by filtrating and eliminating certain substances. We have hemopheresis and we have plasmapheresis that will keep the plasma and return the elements to the donor. Now, depending on what is the cause of the condition, probably the most typical type of hemopheresis is that you heard about. It is the dialysis machine that helps to filter the patient's blood from all the waste products that the kidney is not able to do that anymore. Plasma on itself may be given in certain cases of emergency, and we can give it whenever we need to replace blood volume and to prevent any kind of circulatory failure, or in other words, it's called the shock. So whenever the blood typing and the use of whole blood is not possible, plasma is very useful. And it's usually in natural disasters or in emergency situations can be used. Now, why is the plasma so good in those situations? Firstly, because I can give it to any patient without even doing any type of matching, because the red blood cells were eliminated and leukocytes were eliminated. So everything that will create an immune response are already removed. So we have them in several concentrations based on the serum albumin. We have solutions of 5% or 25%. Once the plasma, and which, if you remember, the main component of the plasma will be the albumin, will be transferred to the patient, that will increase the osmotic pressure inside the blood cells. That will attract the water from the tissues and will maintain the water inside the patient's blood vessels. By doing that, will increase the blood pressure and will maintain an adequate circulation in the blood. However, we will need, if there is a hemorrhage in that patient, we will need some kind of support with red blood cells, because the red blood cells are the main transporters for oxygen. The oxygen dissolved in the plasma is only in very limited, very low levels. So red blood cells are needed. We can use in some extreme situations plasma expanders. Those are what are called cell-free isotonic solutions that will maintain a certain blood volume and will prevent the shock. Fresh plasma can also be frozen and saved. Now it needs to be used whenever there are any kind of clotting issues. Once is thawed, it needs to be given immediately. It's called the cryoprecipitate. It's rich in fibrinogen and clotting factors, and we are giving them to those patients that are bleeding profusely while we are trying to fix their bleeding issue. We'll discuss now types of blood disorders, and the blood diseases can affect and involve any line of the blood cells or all of them. And when we are looking at the abnormality may be an increase of the cell number or a decrease of the cell number. Now let's look at the condition that will affect all blood cells, and that is called PAN. PAN means all, pancytopenia. And there will be a deficiency in development of all cells, will be as a result of a suppression of the bone marrow and a disease at the level of the stem cells in the blood, in the bone marrow. Now, if we are looking at just one line, we'll have for a deficiency, we'll have anemia for erythrocytes, and we'll discuss a little bit later in the next slide the white blood cells and platelets. as a result of anemia can be a result of loss of blood, like in a hemorrhage, or loss of particles in a hemolytic disease when the particles are destroyed, may be the result of nutritional deficiencies, and we'll discuss in each of those in a second. When we have an excess of production of blood cells on all the lines, that condition will be called a polycythemia, and usually as a result of a malfunctioning stem cell at the bone marrow, and that's classified as a cancer of the blood. This slide is summarizing both the deficiency and the excesses of the leukocytes and platelets. We'll discuss in details each of those in a second. So let's look at the anemia or the hemoglobin deficiencies. Those can be, again, as a result of an excessive loss or destruction or an impaired production. It's either I'm not producing enough or I'm losing too many. The hemorrhagic anemia can be both acute as a result of a trauma or can be gradual and chronic. Let's say like in a cancer that is bleeding constantly by tiny drops, and in 6 months the patient will be seen with anemia as a result of that colon cancer that is slowly bleeding. We already said that the average adult will have about 5 liters of blood. Now, if as a result of trauma, the patient will lose about 2 liters, which is about 40% of the amount, usually this will result in death of the individual. Now, for those chronic types of blood loss, what I was telling you before is the digestive tract cancers or ulcers. Excessive menstrual flow can bring excessive menstrual flow, may bring also a patient with anemia. Patients that have hemorrhoids, that they're bleeding every time that they are going to the bathroom, also can lead in time to anemia. An increased red cell destruction is defined as hemolysis or hemolytic anemia. Infections may cause anemia as a result of red blood cells loss. We may have parasites that once they multiply inside the red blood cells, they will destroy them, and malaria is the most typical one. We also have certain bacteria, is the streptococci, that will produce a toxin that produces hemolysis. There are some inherited diseases that may produce an abnormal hemoglobin type and result in hemolytic anemia. One example of that is the sickle cell anemia. And it's called like that because the red cells are abnormal. They will be designated as hemoglobin S, and they have a sickle type of shape. They are not biconcave, and because of their cell membrane structure that is abnormal, they are very fragile and they break easily when they are passing through very small capillaries. Whenever normally the patients that have this condition will have lower level of hemoglobin than a healthy individual, but they can go through what is called a sickle cell crisis, and then it's a severe destruction of this type of cells, and usually will result in severe joint swelling and pain, especially at the level of the fingers and the toes. This is a condition that is inherited. It's most common in North African countries' descendants. In US, it's seen in about 8% of the African Americans being carrier of this gene. On the other end will be an impaired production of red cells and or hemoglobin. And this will be the result of some nutrients that are missing or some impaired development at the level of the red bone marrow. One condition will be nutritional anemia, and that results from a deficiency of a nutrient. It can be iron deficiency anemia when we don't have enough iron that is essential for building the hemoglobin. Um, Usually, iron is found, especially in meat, in poultry, and fish. Vegetarian may be found with iron deficiency anemia if they are not eating green leafy vegetables. We may see also a deficiency of, if you remember, we need for that, we need the folic acid and B12 vitamins. So folic acid is also one of the B complex vitamins. Um, the folic acid deficiency is seen in alcoholic people and in elderly that have poor diets, and also in infants that have some intestinal disorders that will impair the ability to absorb this vitamin. Pernicious anemia is the deficiency of vitamin B12. It can be associated with an intrinsic factor deficiency, that is um, a deficiency at the level of the gastric juice that impairs the vitamin B12 absorption. The main issue with the vitamin B12 is that it's found in animal origin products only, and it's also something that is seen in strict vegetarians. They will need supplements of B12. We can have thalassemia, and thalassemia is a hereditary anemia, and um, is a this defect will um, produce an abnormal type of hemoglobin. And the main issue with those type of erythrocytes is that they may be destroyed um, at the level of the bone marrow even before they become mature. So those red cells are very small and pale, and they have a low level of iron, just like in the iron deficiency anemia. Um, as opposed to the typical iron deficiency anemia patients, those patients will have the pale cells with high levels of iron deposits in their body because of the high destruction of erythrocytes and the low usage of iron when they are manufactured. Just like the sickle cell disease, the thalassemia, and especially the beta type, are found in Mediterranean descendant population, um, the Greek region, and North African countries. And the last type of impaired production would be at the level of the bone marrow, when there is a bone marrow suppression. That type of anemia is called aplastic anemia. It can be a result of the physical or chemical agents that will injure the bone marrow stem cells. They can be drugs or toxic agents, as gold medication. We have some gold compounds that we are using in some um, autoimmune conditions. Arsenic, benzene, X-rays, atomic radiation. All of those will damage the stem cells, and as a result of that will be a decrease in production of red blood cells. Another type of bone marrow suppression we see in patients with chronic diseases, especially cancer or end-stage renal failure, in some of the patients that have liver disorders or chronic viral infections. Um, and especially for the chronic conditions as cancer or end-stage renal failure, we can use erythropoietin to increase the production of red blood cells. This is a microscopic image showing you the sickle-shaped cells, and you can see how they are not looking like the normal-shaped cells. Um, Not all of them are malformed, only some of them. But by being in high quantity and being destroyed all the time, they will cause all the signs and symptoms in this condition. Leukemia represents a neoplastic disease of the blood-forming tissue, and it will be usually characterized by an extremely increased production of white blood cells. Um, However, they can be present also as a decreased number. um, despite the fact that those increased white blood cells, increased number of white blood cells, usually they are um, not fully formed. They are called incompetent. They are not able to perform the needed function, um, and they crowd out the production of other cells, and they will impair the production of other cells. So the white cells will develop in two locations. One will be at the level of the red bone marrow, and that level is called the myeloid tissue. And as a result of a malfunction of this tissue, will have the myelogenous leukemias. And others will develop at the level of the lymphoid tissues where they mature. And if the leukemia develops over there, it's called the lymphocytic leukemia. They both also can have two forms. They can have an acute form and a chronic form. They can be the result of inborn factors or as a result of environmental action of some agents as chemicals like benzene, X-rays, radioactive substances, or viruses. Most of the time, the patients with leukemia will have also general symptoms of anemia because the neoplastic tissue will take over all the parts of the red bone marrow and will impair the normal production of red blood cells. Will also lack normal level of thrombocytes of platelets for the same reason. In addition to that, the white blood cells that are produced in high number are inefficient. So the patients will have infections that can be frequent and serious. In addition, with all those elements, the spleen will become enlarged because the spleen is trying to remove all those inefficient and improperly functioning white blood cells. And as a result of over functioning of the spleen will be enlarged. The treatment of leukemia is usually chemotherapy. Um, we can do also bone marrow stem cell transplantations after we expose the patient to extreme radiation to completely kill all those stem cells that are malfunctioning. This is an image that shows you compares and contrasts a normal blood smear under the microscope, and you can see the white blood cells and the small amount of white blood cells and how do they look when they are normal. And you can see an acute myelogenous leukemia where you see the malignant myeloblasts that they are big, they look malfunctioning, they look like a little monster, and they are in huge quantities and they are taking place of other cells. Clotting disorders represent disruption in the platelet plug formation, or it can be at the level of the platelet plug, or a disruption in the coagulation cascade that will result in abnormal bleeding. Now, on the other hand, we may have conditions that are characterized by an excessive clotting. So we have one type of condition that affects the clotting system is the hemophilia, and that's a pretty rare hereditary bleeding disorder. Back in the day was called the royal disease because Queen Victoria, and she ruled Great Britain in 19th century and even before, was carrying this trait, and usually the hemophilia is passed by the female, and all the signs and symptoms are seen in the male offsprings. It was plaguing the Russian Tsar family also. In all those forms, there are a few forms of hemophilia. They are characterized by a deficiency in a specific clotting factor. The most common one is the factor 8. As a result of this condition, any injury may cause either excessive bruising or serious and abnormal bleedings with big loss of blood. Whenever the bleeding happens in a joint, because kids will run and will fall and will hit themselves, and in children with hemophilia, the bleeding can happen inside of joints from even small injuries. The joint will swell will become very painful, will not be able to use the joint for a while, and is the process of healing chronic not malformation, chronic changes will happen at the level of the joint, and that will become arthrotic at a very early age. Now, in a modern time, we can use cryoprecipitate that will have factor 8 inside. We can give them whenever is needed, whenever they're injured, exactly the factor type that helps them to prevent any type of excessive blood loss. A second type of clotting disorder is the von Willebrand disease, also hereditary clotting disorder that will in this condition, there is a malfunctioning, there is not enough von Willebrand factor, which is a plasma component that will help encourages the platelets to stick together to damage tissue. And in addition, the von Willebrand factor will also transport the clotting factor number 8. So both of those segments will be affected in the clotting process. Another kind of clotting disorder is a result of thrombocytopenia, a very low number of thrombocytes. And this may be a result of decreased production in the red bone marrow or an increased destruction. An increased destruction can happen at the level of the liver or a malfunctioning spleen. Specific type of conditions and very serious disorder characterized by excessive coagulation is what is called the disseminated intravascular coagulation. In this type of condition, the tissue damage will usually caused by massive burns or trauma or acute and very critical infections may start a cascade of clotting inside the blood vessels. So small clots will develop throughout the body, and as a result of that, the blood flow will be reduced in some tissues or impaired completely. And while this condition progresses, the platelets will be used and destroyed, while the anticoagulant elements inside our bloodstream will try to counteract this pathologic process. And as a result of that, the patient will show both signs of blood clotting inside the blood vessels and bleeding from any type of tissue or injury. We'll discuss now about types of blood studies and how can we understand and diagnose conditions. Most common one will be what is called a complete blood count. A blood sample is taken from the patient, and the machine is able to, on that blood sample, to perform a few counts, a few determinations. And the first one will be what is called a hematocrit. And the hematocrit measures how much of the blood volume is represented by the red blood cells. It's a ratio, in other words, it's a ratio of blood cells to the blood volume. In other words, the hematocrit may give me an estimate of the oxygen carrying capacity of the blood. So when I'm saying that, it means that whenever a patient is anemic, the hematocrit will be low. In general numbers, for a healthy individual, for men, the value of the hematocrit ranges from 42 to 54, and for healthy women from 36 to 46. It can be influenced by, again, several conditions. Whenever there is a condition that will generate an anemia, we'll see a decrease in the hematocrit. Whenever we'll have a polycythemia with an increase of the number of the red blood cells, we'll have an increase of the hematocrit. Now, if you look at the fourth test tube, the further right on your screen, you will see that we can diagnose even dehydration by an increase of the hematocrit as a ratio to the full amount of volume as a result of reduction in the plasma/ the water component in the blood. In the red blood cell, in the complete blood count, we can look into the red cell count. That normal would be 4.5 to 5.5 million cells per milliliter. It will be increased in polycythemia when we have more cells than needed, or decreased in anemia. We have the white cell count, again, varies between 5,000 and 10,000 cells, with increased one leukocytosis for bacterial infections or cancers of the blood as leukemias, or decreased as leukopenia for bone marrow issues. We can determine the blood count, the platelet counts, with a normal range between 150,000 to 450,000 per milliliter, with low levels being associated with an increased risk for excessive bleeding. When we need to look a little bit more intimate into the morphology, the way that the cells look, the ratio between them, we can do a blood slide smear, and we can observe the red cells in terms of their shape. Platelets, parasites may be identified, and we can even see different shapes and morphologies in the white blood cells. On blood, we can also perform chemistry tests. The most common one is the Chem7, that looks into sodium, potassium, chloride, and bicarbonate, blood glucose, blood urea, nitrogen, and creatinine. So it looks into the electrolytes and the most essential kidney functions. We can also measure levels of LDH, lactic dehydrogenase, or alkaline phosphatase. Those are elements that will give me information about the liver function. We can test lipids, we can measure plasma proteins, we can determine levels of different hormones, we can determine and even harvest antibodies, and we can measure and evaluate drug levels. Coagulation studies are usually performed before surgery or whenever there is a risk for an increased bleeding. So what we can do is to measure the amounts of clotting factors in the blood. We can perform a test that is called a bleeding time. Another one is the clotting time clotting time is easy to perform. We just take a blood sample in a tube, we'll put it aside, and we measure the time until we see the clot forming at the base of that testing tube. Other tests will involve capillary strength and platelet function. Last test that we'll discuss about today is the bone marrow biopsy, and that provides us information about the stem cells and in terms of how do they look morphology and their function. We perform that by using a needle that will puncture and will remove tissue from a flat bone that can be the sternum, the sacrum, or the iliac crest. In this condition, this type of test is used for diagnosing bone marrow disorders as leukemia and some types of anemia that we are not able to diagnose a specific cause by other tests. Question number 2. The hematology specialist needs to measure the number of eosinophils in a blood sample. Which test should she conduct? A hematocrit, an electrophoresis, a bone marrow biopsy, or a differential white blood cell count? In order to measure the number of eosinophils in the blood sample, we need to perform a differential white blood cell count.